All right, it looks like we've got a quorum and no one's waiting in the waiting room, so you can go
Excellent.
ahead.
Thank you, Isabel. Good morning, everyone. I'm Dr. Judy Richardson. I'm the co-chair. Actually, I'm the vice chair of this committee. This is our special board meeting. I'm sitting in for Chair Belanca, who will join us momentarily. Mimi, if you don't mind, let's take a look at the agenda this morning. We're going to discuss the revenue replacement target as well as the plan lever options and discuss our next meeting topics as this work continues at a frenzy pace rapidly towards our report for the legislator and then ongoing work. So we will also have some public comment at the end. Thank you. Let's go.
And before we get into it, do we want to do a roll call?
Oh, yeah, there's that. It wasn't on the agenda.
Yeah, let's do it.
Thank you as well. Please do a roll call and tech check.
So I know Helen Belanca is on her way and will be joining in a few minutes. Judy Richardson.
I'm here.
Thank you. Chen Wei Chi.
Here.
Thank you. Amy Fellows.
Here.
Thank you. Michelle Glass.
Here.
Thank you. Cheryl Ramirez, I think is unavailable today. Mary Lou Henrich.
Here.
Thank you. Mike Leahy.
Present.
Thank you. And Bruce Goldberg is unavailable today, but will be joining for the next one. So thank you, everybody.
Wonderful. Thank you, everyone, for joining at this special time and day for our board meeting. Take it away, Dr. McDonald.
All right. Thank you, Vice Chair Richardson. So good morning, everyone. This is Mimi McDonald, Executive Director of the Universal Health Plan Governance Board. And so for this first portion of the meeting, what my plan is to go over how the 2032 revenue replacement targets, and I say targets because we actually have a sort of a range, were attained, kind of going back to calling back to some of where we started with building the revenue plan with the Optimus report and how that is now changed to utilizing the information from Milliman and also utilizing a significant amount of information that we've had from other sources like Dr. Kant, Dr. Chow, and others to really fully understand what we think the expenses will be for a universal health plan and what we think the savings will be. So we'll go to the next slide. Thanks. So what is the revenue replacement target? So as people who have been following along are pretty much aware, like that is the amount of funds that is not covered by all the federal and state resources. So in other words, that's the amount of money that the Finance and Revenue Committee and the board has been targeting as a sum to be raised in a different way than under the status quo. So again, under the status quo, we know that the funds come from multiple different places. So employers contribute funds towards health insurance in multiple ways. And of course, individuals do by paying premiums, by paying deductibles, by paying co-pays, by paying co-insurance, et cetera. So that revenue replacement target, again, is the amount of money that is expected to be needed to be raised under this universal health plan. And how do we get to that? Well, the first step is calculating what an annual healthcare expenditure under a universal health plan would be, then subtracting out the federal contributions that are made, so to Medicare, Medicaid, on the exchange, and also block grants. Also taking out the state contributions that are in the status quo that are currently going to Medicaid and some other state funds. And that's where we land with the revenue replacement target. So I'm just going to stop for a second, make sure everyone's on board with this. See any hands? So super. Moving on. Okay, so now I'm going to talk about, and I'm referencing from the Milliman report that they provided, and there's this is part of the materials. And this has to do too with the discussion that we had at our last board meeting. So this should all be very familiar. So Milliman, when they did their actuarial estimates for 2032 Universal Health Plan expenditures, came up with a range, a low, a high, and what they called their best. So those numbers that are in that thing that says step 1, that is, let's say, the whole enchilada. So that is what is expected to be the entire cost. And this is again based on claims of a universal health plan in Oregon if everyone who we have described is covered, and all of the benefits at that PEB plus level are covered as well, and administrative costs. So everything. All right. So we did that. That's very clearly in the report. Now, as we discussed at the last board meeting, doing an adjustment for administrative savings and also for collectability, because as I mentioned, those numbers come from claims data, and we know that frequently providers are not able to collect all of the funds that they bill for. And so when those are taken into account, those provider administrative savings and the funds that are what we call from collectability, we come up with lower numbers. So that's where we get the low, the best, and the high. And this is figure 50 in the Milliman document. So again, I think we're all in agreement on that. And we've been over this at the last meeting. So on to the next step. I think, yep, one more. Thank you. Okay. So now, and now this is something that is different. So something that we're introducing to this discussion today is there has been a lot of discussion around that the estimated payer administrative savings, which in Milliman roughly, they had a range, but was around 6%. Instead of using a 6%, these are estimated using a 3% payer administrative cost. Now, of course, this would be in sort of a steady state land, right? So this would be like the absolute minimum. This is much more on par with what Medicare fee-for-service is and what Medicaid fee-for-service is. So this is a significant difference, and I wanted to call that out. But I wanted to call that out so people are aware of all of the savings that are being taken into account when we look at these numbers. And you can see that it does, it does make a difference. By about at the low end of it for about $1 billion. Now, the reason that we're not using the high estimate, and you'll see that little asterisk there, the high estimate that was calculated by Milliman, that $86.5 billion had, and I apologize because I had to pull this up and I forgot, it's about a 7% annual increase in healthcare costs from their initial 2026 estimates up to 2032, which is felt to be much high. It's much more likely to be in the 4 to 5%. So again, so that's not talking about administrative savings. That's talking about how much is when it's projected into 2032. So again, I'm going to pause there for a second and see if there are any questions, because I wanted to be clear about why that high number was that little asterisk. We're not going to use that high estimate for Milliman anymore. Okay. Thank you. All right, Isabel will take us to the next slide. Okay, super. All right, so now on top of that, and again, this is something new that we are introducing when coming up with this revised revenue target. There has also been discussion around what would it, that the estimates from Milliman, perhaps, which is true, did not take into account a potential for an expenditure reduction related to prescription drug savings. It also did not take into account a significant reduction in expenditure related to reduction in fraud, waste, and abuse. So, and these are very, I mean, they're based in actual estimates. A lot of it is based in how much in the New York report estimate of how much savings are potential, and then even further reduced from that. If we think about prescription drug savings, obviously, Oregon is a very small state, and the potential that of being able to reduce prescription drug cost is lower than it is, say, with a much, much larger state like New York, which has much greater purchasing power. But it is, again, taken into account. So we're really trying to pull in all of sort of the getting to most optimistic, as it were, estimate of what could be saved under a universal health plan. And again, although we know 2032 will not be steady state, but that's where we're going with it. Those are the assumptions. So again, wanting to be clear. All right, moving on again. Next, this is how, remember we were talking at the beginning about how we get at the revenue replacement target, we have to think about how much would a universal health plan be getting from the federal government, and also how much from the state if we, again, this is a big assumption, if we assume the state is able to contribute sort of under that general fund, the same percentage amount that it does under status quo. So that's where these numbers come from. So we start off at the top, excuse me. So we're going, as I mentioned, we got rid of the high Milliman estimate. So we're going with the best and the low. If we look at row A, this is what Milliman estimated from figure 43 that CMS would contribute. So this includes contributions from the federal government that go towards individuals on the exchange who are eligible, also for Medicare and also for Medicaid. And you will also notice that just look closely that 23.4, those are in 2026 dollars, because that's what the Milliman estimate was in. So it's a little bit lower than it will be in 2032. That's one estimate. Next, how much does the state of Oregon via the general fund contribute? And that number is there. The number that was in the table was exclusive of coverage of dental. So keep that in mind, because we're going to add that dental back in. But if we just do A and B, then we get row C, which is just adding those two. Now, if that contribution is now trended from 2026 dollars up to 2032 using a 5.3% trend, then we get to those numbers of best of 38.9 and a low estimate of 35.7 billion. We're over there. We are going to now add back the estimated contribution to dental that the state would give. So just think, how much does the state cover currently? And this is mostly Medicaid members for dental, and that's at 0.8 billion. That would be in 2032 dollars. And I see Mary Lou has a hand raised. Yes, please.
Yes, I have a question on, so there is currently no federal money helping to cover dental Medicaid folks?
Well, that's a great question, or a great point, Mary Lou. And yes, because of matching funds, there probably is. So there may be some more of that to be able to add in. So that's a great point. We were just estimating what came from the state. So there may be some dollars if we think about how much the federal government contributes. So I think that's something that is a great call out, and we can add that in.
Great, thank you.
Thank you. A little note for federal dental. Sorry. Okay. So then, yep, we get down to F, which is adding that dental contribution from the state, as I mentioned, and those are the numbers that we come up with. These are, the estimates do include kind of the changes in the population that's estimated. So in other words, in 2032, it's estimated we'll have an increase in people who are eligible for Medicare. So again, as we know, our population in Oregon is changing a little bit. All right, so we're going to go on to the next slide. And thank you for doing math with me this morning. All right, so now we come up with three numbers then. We have a best, a low, and the lowest. The lowest is the one that had the contributions related, or sorry, it had the expenditure reduction related to a reduction in prescription pharmacy costs and a reduction related to fraud, waste, and abuse. So that lowest is the most optimistic number that we have. And that these are the numbers that were actually sent to LRO. So again, that's how we came up with all of these. And I just wanted to make sure that everyone was clear and also to have an understanding. And of course, there's so many assumptions that are made in all of these. And it's a little bit crazy when you think about billions of dollars, but this is, this is the information we have, and this is the best that we can do for this for right now. Okay. Let's go on to the next slide. Okay, so I'm just going to pause there. I'm trying to see if Chair Belanca has been able to make it.
I did. Hi, everyone.
Yay! You right in the nick of time.
Yeah.
All right, I will, if it's okay, I'm going to let you take it away, Helen, for right now.
Sure. Good morning, everyone. Sorry for my delay, car troubles. What we have been planning on is that we've given the revenue replacement target and our basic structure of our revenue strategy to LRO. And they're going to come up with those revised actual percentages from each of the portions of our revenue strategy. So for instance, what would the HCPIT now be given these new estimates of our revenue replacement strategy? What would the payroll tax be given this new revenue replacement strategy? Based on what Mimi just showed you, we can anticipate that those percentages are going to be higher than the ones we've been ballparking. If you recall, the Finance and Revenue Committee, when they were building the revenue strategy, was the only thing they had to use was the Optimus estimate for the revenue replacement target. They were using 2026 numbers. It was around 17 billion. If you project those forward into 2032, it's probably 21 billion. And as Mimi just showed you, our actual revenue replacement target is much higher than that. And so we need to have a conversation about if we want to adjust anything about our revenue strategy based on this information. We don't have those actual percentages yet. We anticipate we'll have those for our regular July board meeting next week. But until we get those, before we get those, I think it's worth it to have a conversation about what we want to do, if anything, to adjust our revenue strategy. We are not voting today. There will be no decisions. We're just trying to go through the list of possible levers for adjusting our revenue strategy and get a feel from all of you about if there are any that you feel are totally off the table, if there are some you'd rather do than others. What we're hoping is to go through the levers one by one and get a sense of what they are, what they would do to our revenue strategy, what they would do in terms of how much money they would save or contribute, and then break them up into categories. These levers, we don't want to touch at all. We don't think that's the right approach. These ones should be our first go-to levers if we need to adjust the revenue strategy. These, are the middle ones, and then these are like our third and last option kind of thing. So we're basically just going to try and break them up into tiers. But again, there's no vote today. We don't have the numbers. We don't know exactly how this is going to work out. But I think we need to be prepared to adjust our plan a little bit in light of how high this revenue replacement target is. So is that clear what we're doing today? Does anyone have questions? And I need help because I can't see the chat or hands if anyone has questions.
I'm not seeing any hands right now. I'll let you know, Helen, if someone raises their hand.
Okay, cool.
I take it back. Mary Lou just raised her hand.
Okay, go ahead.
Wanting to know, can we go back? Oh, are we going to go back? I'm sorry, Helen, when you were going on, my brain was kind of racing, and so you may have said this. But in terms of some of the estimates, I guess there are a couple that I've been looking at in the Milliman report that I don't know when is the proper time to discuss. But for example, the number that they used for dental coverage, I believe is really too high. And I've been talking with the, head of dental at Kaiser, the head of dental for Care Oregon and Multnomah County, and for Medicaid, and looking at the utilization rates and the actual amount per year that those say. It seems to be between 40 and 45% of the total users that you have will use dental in a year. And then the number that they are variously saying that cost per year is, and I really believe there's at least $1 billion, because Milliman estimated 3 to 4 billion for that. And I don't know, I'd like to know, I'm still trying to get more specifics, but I mean, I'm wondering, is there a possibility to look a little bit at that revenue replacement target with, I know you looked at the pharmacy, bringing it down 1.5, and said that was because the New York was higher than that, we're smaller than that. But what about, the idea of the multi-state collaborative that Array RX? I mean, I'm just wondering, are we going to be able to kind of talk about, is there really, I'm not talking big billions here, but I'm talking some minor things, and also the part about, the number of people that induced utilization, the number of people moving into the state, kind of thing. So those are the
Yeah.
three that I think I'm not totally comfortable that it feels a
Right.
little high. That's all.
So, I mean, Milliman has their professional standards for how they come up with those numbers. And I trust they're the experts, they're actuaries, to figure out what those numbers should be. I'm not in a position to know if they're accurate or not. That's not my expertise, it's their expertise. And so these are the numbers that they've given us to work with. And what I would say, Mary Lou, is that we are out of time for that. We have to sign off on a final report at our August meeting. And after our report, we will have time to sort of rehash and rethink things. But for right now, for the purposes of the work that's in front of us for today, I think we just need to go with the numbers that they've given us. And if we want to have somebody else look at them, have another consultant look at them and see if they come up with something different, there may be time for that at a later date, sort of into next year. But for right now, these are the numbers that we need to work with, and we need to stay on target and come up with a revenue strategy, right? The overwhelmingly number one priority of this board and this report is a revenue strategy. And I know the numbers are high. They're higher than everybody predicted, but they're the best numbers we have to work with. And I think we just need to go with it for now. And then later on, we can ask another consultant if we need to kind of relook at them. But it's what we have to work with right now.
And
We
Amy
don't have the
has her
time.
hands up.
We're out of time.
Okay, I have a, I have a potential why anecdotally, that big discrepancy, Mary Lou, having a teenager that's on OHP. Medicaid dental in this state has huge backlogs. In April, my kid got put on Advantage Dental, and they gave me a get to know you appointment for January 2027. So the reason the Medicaid numbers are so low is because they create a sphincter for lack of a better word, but like it's the access is not there in our state the way that we have our Medicaid dental set up. You can't go to any dentist with Medicaid dental. You're funneled into certain places, and there's huge backlogs. So maybe the number's somewhere in the middle. I don't know, but I think that's possibly why the Medicaid numbers are so low.
And I wasn't really using the Medicaid. I just gave that as an example,
Yeah.
but it was really the Kaiser numbers that I was looking at more, that I thought was more just, accurate in terms of just kind of general
Mhm.
folks. And also I think Medicaid dental in Multnomah County is apparently different. But anyway, I just was looking at, at some various things going back. And so, but I'm hearing Helen say it's too late. So thank you.
Chunwei has his hand up.
Go ahead, Chenwei.
Yes, I have two combination of comment and question related to this part, and then later I have more. The first is a question. With the relative high replacement
Target.
target, the flat tax rate will be very high, perhaps higher than what anticipated.
Yep.
My question is, have we done enough community outreach to gauge what is the acceptable rate? And on a related issue, let's say if we propose a 10% flat tax rate for the household health income tax, even though in reality that will not be the final effective rate. However, we will be a communication disadvantage because for those who oppose to this whole universal health plan, they will use the 30-second soundbite to say, see, they're taxing us for 10%.
Right.
And the effective tax rate cannot be explained in a 30-second soundbite.
That's right.
And with that 30-second soundbite, they can easily defeat in a ballot measure
Right.
about this. So
Yep.
the communication strategy is vital. Together with come up with, if possible, a lower flat tax rate.
Yeah,
And so that's
absolutely.
my first question.
Uh,
And the
ki-
second related to that,
Mhm.
and related to the whole report, is so far we haven't carefully discussed and considered, one, whether this will be a big bang that we implement on spot, everyone covered, or this will be a phase-in. And these two alternatives have a tremendous financial implication. If this is going to be a big bang, then everything, and including the revenue target, has to be on spot by 2032. While the potential saving will not be realized in 2032. So that's the implication of Big Bang. On the other hand, if we decided to go or recommend phase-in, say takes 4 to 5 years to gradually phase in different groups, then there's a whole different implication of revenue target, as well as potential saving gradually realizing over that 4 to 5 years.
Right.
And so these are important issue to consider because it have a vital impact on our revenue target.
Yeah, that's absolutely right. I 100% agree with all of that. The answer to your first question is no, we do not know what is an acceptable rate to the public. We haven't done that work. That's part of our communication strategy for 2026 to 2028. But our goal today and our goal before the report is to really consider ways that we can lower that flat rate as much as possible, because you're right, whether it's 9% or 15% or something else, we have to get that as low as we can. And so what are the levers that we're willing to consider to lower that rate? Because you're right, it's going to be really hard to communicate the complexity of an effective tax rate. But we have time to work on that. That is not our goal today. We're not going to solve that before September. We're going to have time to sort of wrestle with that in the coming years after this report is. Our goal today is to think about how to optimize our revenue strategy so that we can present the lowest rates possible, because you're right, like the higher they are, the less likely it is to be sold to anybody, to the legislature or to the public. Regarding the implementation, of course, you're absolutely right. This is what we discussed at our last board meeting. There was a pretty clear consensus, I thought, from the board that the phase-in approach was the right way to go. As Lee mentioned at the last board meeting, we're going to present all of those options and their implications, as you alluded to the legislature. It'll ultimately be up to the legislature how they would proceed with that. We would indicate in our report that our preference is for that phased-in approach, partly because of what you said, that it would, be a gradual rate increase. But that makes the most sense because you could cover more people more quickly, right? And so instead of waiting on the waivers. So we handled that at our last board meeting. That'll be reflected in the report. And today we just need to think about how do we optimize the revenue strategy to present it in a way that's most likely to be successful. Anyone else with questions?
Judy.
Let me just make a quick comment. One of my major concerns is if we say we continue to work on revenue target as well as savings after September, but if we submitted that in September, this become an official public document.
Yep.
Those who oppose to this plan have plenty of time to prepare the attack, where we are still preparing how to defend it.
Yeah. We don't really have any other options, though. we have to get something in front of the legislature in September, and we're going to do our best to present our best recommendations as we have them now. We don't have the resources to do a more thorough vetting for that. So we do have time after that's submitted. We can indicate in our report that we're going to continue to work on optimizing it, but we're due to give them an update on our plan and to get things rolling in terms of a legislative concept. So we're going to do our best to optimize it with the very limited time we have left, and then continue to work on it, because this board does not sunset. It's our job to continue to work on it and refine it.
Judy.
Thank you, Chair. So I'll be very brief, and I know this sets up the next slide. And I just want to challenge my fellow board members this morning. This discussion is intended to be a strategic one. I know that we oftentimes really get stuck on the numbers and doing the math. And thank you, Mimi, for presenting math. But let's try and take a breath and elevate above that math and think about strategically, what can we do when there is a gap in funding? What are the measures? And if you've haven't had a chance, I suggest that sometime take a look at the advisory group on Medicaid report that was just landed in the Office of the Governor yesterday or this recent week, because they outline a whole bunch of different things that can be done that align with the principles set out by that group to improve the bottom line, if you will, to reduce that gap in funding. So that's our role, I think, today. I think that's really important work for us to do, is to, if we can, compartmentalize the reality of the actual numbers and think strategically and maybe creatively about what those levers are, those buckets, those things that we can do to shrink that. Does that help?
Mm-hmm. Yeah, thanks, Judy. Okay, let's go through the levers. I'm going to turn it back over to Mimi to go through the possible levers. And for now, I just want to go through all of them. If you have clarifying questions, that's okay. But I don't want to have any discussion about any one of these levers until we get through the full list. And then we can sort of have a discussion about them overall. Does that work? Okay.
Michelle, you have your hand up.
Just very briefly, just want to recommend, thank you, Vice Chair Judy, for the strategic framing. I also just want to say, I think this is a critical place for our principles and values that we worked so hard on, to have those in front of us as we listen and think about these various strategies. So I have them pulled up and we'll be having them in mind as we go through this. So just wanted to offer that.
Yeah, thank you, Michelle. That's excellent. Yeah, Michelle and Judy, that's a great callback. So this is a strategy discussion. This is a principles discussion. So keep those in mind as we go through these.
All right. Thank you, Chair Belenka. So as mentioned, we are going through these. So let's go on to the next slide. Oh, and thank you, Michelle, for putting that in the chat, our overarching values. All right. So as Helen alluded to, today's discussion, my little puzzle pieces up there, has to do with if there are aspects of the revenue plan that are not feasible. In other words, tax percentage rate just seems too high that would ever be palatable. What tools or levers exist to make changes? What are the estimated financial impacts of the changes? And you will see, if you looked ahead at the slides, you'll notice that the estimated impacts are not in dollars. They're in what we call t-shirt sizes. So it's small, medium, large. I didn't even have extra large, but maybe we'll do that. So it is very broad. And of course, because there's a lot of nuance to it, what are the trade-offs? Of course, if you move one lever, something happens to something else. And this is one thing that I would really, really appreciate from the board. You don't have to provide it right now during the meeting. Certainly do if you can, but even between now and next week, if there are like data points like, oh, I want to know the percentage of X, Y, or Z or things like that, for short term and longer term, please keep that in mind. Send me an email, do whatever, and we'll do everything we can, staff, and working with Morgan and with other our amazing committee members to get that information in front of this board. So that's my selfish hope for this meeting as well. So we'll go on to the next slide. All right. So the first one has to do with changing the relative contribution of the revenue instruments. So I'm just going to take us down memory lane. I will tell you what we put in front of LRO was that if we think of the revenue replacement target as being 100% of the pie, corporate income tax would be 3.8% of that. Corporate activity would be 1.3% of that. The employer payroll tax would be 51.4%, healthcare personal income tax 43%, and lodging tax less than 1%. So those are the ratios that the board decided, kind of what was developed initially by Finance and Revenue, and the board went along with it. We made some changes along the way. Oh, thank you, Michelle. I appreciate that. For anyone listening, LRO is the Legislative Revenue Office. I appreciate that. So obviously, if the decision was made, the healthcare personal income tax is too high, is that number, that rate seems too high, what could happen? Well, you could say, all right, well, we think the corporate income tax needs to go up. So more money will come, the percentage will shift to the corporate income tax, and we will ask for less from the healthcare personal income tax. Now, of course, depending on how much you move that lever, it could either have a very small impact or it could have a very large impact, depending on how much you wanted to change the percentage. So that's something I think for board members to keep in mind. And so again, just the big ones are employer payroll tax, about 51.5%, healthcare personal income tax, 43%. So that's one thing. Next, and this is a very large discussion point, and I think I saw Charlie Swanson, who I may phone a friend later as we get into it, not for right now, but what are the repercussions of eliminating that employer payroll tax credit, eliminating the employer payroll tax credit, that 50% tax credit, where the funds that are generated from that employer payroll tax go back to employees. Well, that would have a huge impact. That's, many billions of dollars. So what would that look like? Well, if that tax credit was eliminated, one could lower that top number of the healthcare personal income tax, but then remember, there's actually less dollars going back to those employees. It also serves the purpose of kind of distancing even further healthcare from people being employed. And I see Mary Lou has her hand up.
I'm just thinking that it could also say that we didn't necessarily, we're at 50% right now, and we debated back and forth on that percent. So it could potentially not be eliminated, but it could be lowered, maybe 25% or something like that.
Absolutely.
Just
No,
a thought.
thank you. That's a very, very crucial point. Thank you very much. Yes, it could go from 50% to 25, or it could go higher. Thanks, Mary Lou. I really appreciate that. Next, and this is estimated, this would have a smaller impact, would be to change the exemption level. So instead of the first dollar being paid towards an employer payroll tax, starting at $500,000 annual payroll, if that was actually lowered, it would be starting at $300,000. So in other words, companies that pay less payroll would start contributing sooner. So in other words, that range between $300,000 and $500,000, those companies would actually start to contribute some to the revenue plan, to the revenue target. So let's stop there for a second. Looking good. All right, we're going to go on to the next slide. All right. Oh, Mary Lou, do you have your hand up again?
Yeah, I'm sorry.
No. Do you want to go back or?
No, it's on
Okay.
the employer payroll tax thing. And one of the things that I have talked with Charlie behind the scenes, just understanding more about it, there's the potential also of tiering that, making it.
That's on the list right here.
Is it later? Okay. I missed it.
It's
All right.
That's okay.
Wonderful. Oh, I
It's
see
my
that.
next
Add
point.
tiers to both. Okay.
All right. So, and of course, the board has discussed this. What if we add another revenue instrument? Again, this could be small to large. What if a sales tax was added, or a wealth tax? So again, the amount of the sales tax or the amount of the wealth tax would determine how much the impact could be. But those are, very realistic things. Next, Mary Lou, you stole my thunder. The question of adding tiers to the employer payroll tax, or even the healthcare personal income tax. The rationale between adding a tier to the employer payroll tax is that under the status quo, state agencies contribute a very high percentage of their total budget goes into providing healthcare, and not just state agencies, but in particular state agencies do, because most state agencies, the people who are employed by the state, myself included, pay a very have minimal contributions, minimal monthly contributions, have very low deductibles, etc. So currently, state agencies contribute more percentage-wise than private employers do. Mary Lou.
I just guess it's the wording here. Okay, where it says add higher employer tax to state agencies, it would be not just to state agencies, but in my mind, to all really big employers and that have high payrolls. Looking at the city of Portland, looking at Multnomah County, looking at the hospitals that are all currently paying a much higher percentage of their salaries to employee benefits, and wanting to not have them have such a great savings, but get it more closely to what they're already paying. So I guess that's why when I read this, just the way it was written, tax rate to state agencies.
Right. And these are examples.
Okay.
So
others.
but I absolutely appreciate the contribution.
Yeah.
That yes, maybe it's just a tiered for whatever
big, yeah, $10 million
larger
in salary
yes,
or more or something like that.
Absolutely. Now, I will say that that option has not been necessarily vetted in terms of with our legislative revenue office in terms of the ability to do that, but it's very much, it's a theoretical one, but it's still very possible. And of course, we know adding tiers to the healthcare personal income tax, well, that's the way our current state income tax is already. So that one is an easier one. So that would increase the contribution of higher earners. It would reduce the effective tax rate of lower earners, but then that top number would be higher. So again, they're all, puts and takes. Okay, but yeah, thank you so much, Mary Lou. And for people, yes, I think it's important to keep this in mind, that these are what I've provided are examples and potential outcomes. wanted to remind people that cost sharing is a potential lever. And I know this board has discussed it. I put in just the information that Milliman provided, which I thought would be helpful. So for the 2032 estimate, if there was a pharmacy copay, an ER copay, but then also a max out of pocket, that could potentially save, 1.1 to 1.3 billion. That would, well, save is the correct word, but it would reduce the revenue replacement target because people would just be contributing in a different way instead of their tax rate being higher. So this, however, does go more, I think, Michelle, when, sort of thinking about value, this is a good value one to think about, because I think this really highlights that, because this does relate amount of utilization to amount that people pay. So I'm just putting that out there. But again, this is something to think about. We'll go to the next slide. And again, these are more tools. What about a reduction in benefits? So again, using the data that Milliman provided. And again, there was that, as Mary Lou pointed out, maybe that number is maybe the impact wouldn't be that big of excluding dental, excluding vision, excluding fertility coverage, and or other such as what's called occasionally called complementary medicine. And I don't want to, I mean, no disrespect to any therapist at all, but just this is just the way that it was worded, could save potentially $500 million. So that is another one. And then as Chunwei mentioned, well, what about if we phase in populations? Now this is it's not quite back of the napkin estimate, but it's close. So please take this with a grain of salt, and this absolutely needs to be vetted. However, and again, this is taken from Milliman figures, how much additional expenditure is related to those who are eligible for the Medicare eligible population? Well, it's a significant portion. I mean, we know this already, that the population percentage-wise, just as we get older, we have more healthcare needs. So they, per capita, usually utilize more healthcare resources. So the benefit decrease would be the total benefit cost, or sorry, the total expenditure, instead of it being 80.3 billion, it would be closer to 50 billion. However, let us not forget how much money comes in, one, from CMS for Medicare, substantial amount of money. And I would say that and this is again, just making a very large assumption that, of course, if the Medicare population was not included, they would also not be taxed. So there would be a smaller tax base. So putting those both together, that savings of maybe 30 billion going from 80 to 50, well, it's really more like a saving of possibly 10 billion, because you would not get 20 billion from a combination of federal government and tax contributions from the Medicare population. So again, I'll stop there. That was verbose. Apologies. Okay. I see I've baffled you all into silence. Can we go on to the next slide? All right, this again, this is truly for reference, so people can take a peek at it, from the Milliman report, so that where they have it, something with cost sharing, without cost sharing, and then with cost sharing, and also reducing benefits. So those are just the numbers and where a lot of this information came from. So I am going to stop there, because that is the end of the slides that I have prepared, and I will turn it back over to Chair Belanca.
Great, thank you, Mimi. I just want to also, sort of for framing reasons, remind the board that, even with our last discussion, covering all of the benefits and covering everybody, we still estimated that our total expenditures would be less than the status quo, to the tune of $4 billion less. So we still believe that paying for everybody for full benefits will cost less than the status quo if we didn't implement the universal health plan. And again, around $4 billion less. The issue we're grappling with is that so much of the cost of healthcare comes out of people's pockets in terms of premiums and cost sharing and deductibles. And we are translating all of those dollars into a tax. And the sticker shock from a tax is what people are going to be reacting to, even if they will ultimately pay less than they would otherwise. It's just that psychological piece of an enormous new tax. So that's a really tricky thing to grapple with. It is going to be a communications issue. And so we don't want to, we still believe that this is the right, like overall in terms of saving money for the state, moving to universal health plan would save a whole lot of money. But we just have to be aware of how, how we redistribute those funds and where they're coming from, and who the winners and losers are going to be, right? Like who's going to end up paying more and who's going to end up paying less, and how do we frame that? So I just wanted to call that out. And then again, as a reminder, the goal of this conversation is to just talk through any of these options. I guess where I'd like to start the conversation is, are any of the options that Mimi discussed, do people feel that we just shouldn't touch it, that should just be off the table, that they're not aligned with our principles and we shouldn't consider it as a lever?
And Mike has his hand raised.
I wanted to comment not on your question, Helen, so maybe I should defer if someone has comments on your question. I wanted to make some other comments about this. I do want to say that I really appreciate the fact that Helen and Mimi and others have put this together. I do think this is the right conversation of how much of each of these, what combination of this should we be thinking about? While we're making no decisions today, I clearly appreciate the work and appreciate the conversations. I do have a couple of comments on, we will be meeting in our next meeting, and at that time, I guess I will want to make this. I would want to challenge a few things. First, while I appreciate there's some rationale to have pharmacy, basically, a 1.5% reduction in pharmacy to me is a rounding error. I think there are much more dramatic things. I will be later this month meeting with some of the people from Ministry of Health in Singapore to get some other examples of how other places do pharmaceutical reduction. So I clearly want to make sure that that's included in the lever. I also want to better understand how Singapore is putting together their entire information technology and interoperability work. They have a major project with Epic, just like state of Washington does, and I know we'll have that on our next agenda. But that said, I appreciate that we're trying to be strategic here. At some point, though, we're going to have to figure out what are the combination of levers we most want to focus on. So today's,
Exactly.
in terms of laundry list, I want to suggest that we have a conversation at our next meeting, that I continue to be cautiously optimistic that we can actually make overall further savings in terms of providers. I do agree that we're going to probably wind up with a phased implementation, and I've begun to do some calculations regarding that. I still think that it's possible to have as much as 20% overall savings over the status quo, of which 15% could be credited to the universal health plan to not only deal with this piece here, but also begin to deal with our reserves need as well. Those are my comments, and I will
Okay.
appreciate if we could have that conversation next time. Thank you.
Okay. Can we go back 2 slides? So I just want to go through. So the options are to, wait, is there one more? Is it 3 slides? Yes, sorry. Okay, so the options in terms of levers are changing the relative percentage contribution of each instrument, eliminating the employer payroll tax credit, changing the exemption levels. Go ahead, next slide. Adding another revenue instrument, adding tiers to the employer payroll tax and or the HCPIT, adding in some cost sharing, reducing benefits. And on this one, I'll remind people that if we choose to reduce benefits, for instance, if we chose to exclude dental and vision, 2 things are important to know about that. One, supplementary insurance could be available, so people could purchase insurance for those. And because those benefits are part of our Medicaid program, folks who would otherwise be eligible for Medicaid would continue to get those, even if we exclude them from everyone else's benefits. And then phased in population eligibility, basically holding off on including Medicare, in addition to the potential savings in terms of expenditures. That might be an appealing option because it would also be administrative savings. Any waiver for Medicare is by necessity going to include a huge amount of administrative expense to comply with the waiver. And so that's another option. So in that list, I'll ask again, are there any that people think should be off the table that we should not consider just because they don't align with our values, or for whatever reason you think that they shouldn't be included?
And Judy Richardson had her hand up first, and then Mary Lou.
Thank you. It feels like to me, based on our principles, that cost sharing should be the lowest priority on this list. Not that it should be off the table, because I think an appropriate design perhaps would be consistent, but it feels like that should filter down to the bottom of this list, and perhaps to the top. I would pitch for phased implementation, because we've already really vetted this idea for other reasons in transition.
Thanks, Judy.
And Mary Lou.
Yes, I think I would strongly oppose getting Medicare out. I understand the complexities and a lot of the federal, all those issues. But first of all, it's a growing segment of our population. And although there are, I understand, low-income seniors, the data shows that the seniors in this United States and Oregon own most of the wealth. And so to exclude them, just kind of like because you're old and Medicare, I just think it is important that for the revenue, as well as for really having the whole population under the tent, they also vote a lot. One of my last ones that I would agree to would be to drop Medicare.
Thanks, Mary Lou.
Mary Lou, can I ask a clarifying question? Apologies for jumping in there.
Sure.
When you say opposed to excluding, so this proposal is, the phased in portion. Are you opposed to phasing in Medicare? I just wanted to be clear in your position.
Okay, phased in population.
So in other words, that eventually Medicare would be rolled in, but would not be there at the start.
Yeah. I probably could be persuaded a little more on that, but just kind of I just think it's logistically going to be difficult with the older population can be counted on to vote at a higher rate. And I don't know, I mean, maybe there will be people who will say, great, don't touch my Medicare. And leave me out of this thing. Whereas others are like, well, no, I mean, if everybody else is going to have this great benefit and it's, you know, easier and they're going to have hearing aids and I don't, something like that. I don't know. It's just, it's complicated. And I suppose if it was in a strategy plan to show how and when it would come in, but also for the revenue part, I'm ambivalent here. Thank you,
Th-
Mimi, for
Thank
clarifying.
you. And I think Amy, sorry, because my little thing went up. I know Amy had her hand up. Oh, did we lose Amy?
I'm here.
Oh, sorry, there.
No, I just it feels a little in the weeds, but I'm just wondering about like the lump of other things, and like I don't feel like hearing aids are complementary. I feel like those are necessary for communication and well, well-being if you have hearing that's going. So just I don't want to get in the weeds on it, but just as interesting the things that are lumped into other.
Yes, that was from the Milliman report, but I appreciate that.
Yeah, I'll comment on that, Amy. It's just that those are, we went with low-hanging fruit, meaning that those are services and benefits that are often excluded from medical coverage because of their expense. And so those are ones that would be easy to separate out from the overall medical benefits and offer with supplementary insurance. Again, if somebody would qualify for them because of their eligibility for Medicaid, they would automatically still get them, even if they were excluded from everyone else. And then everyone else would have the option to purchase supplementary insurance that would cover those features.
And I just think we need to be careful with the assumption about what is going to be covered by Medicaid in the next year to 2 years. I mean, just looking at that report and the things on
Right.
the table,
Right.
that's
It's in
a moving
flux.
target at
Yeah.
this point. So we could say this, and then it's going to be,
Yeah.
those things will be excluded.
I agree, but that's where those are easy numbers to pull out because they're often excluded from some plans. So that's, and you're right. We could think about, putting other things in that bucket. But yeah.
Right. So Chunwei and then Michelle and then Mary.
I have a few comments. First, a more general comment. Many of those levers were framed as either or, neglecting there could be a range of options. So that's a general comment. And then more specifically, I have three. One is the eliminate employer payroll tax. Earlier, Mary Lou mentioned about that could be a range, not either or. But strategically, there are two issues. That's why from the beginning, I was the strong advocate for giving credit to employee. For two reasons. One, historically, this is peculiar to the United States context. Historically, employer contributed health benefit has been treated as compensation for their salary.
Right.
So that's for equity reasons. And second, for political reason. Imagine if we eliminate that or we lower the rate to the extent there will be sizable people in Oregon who are currently employed and pay $0 to their health insurance premium. They will ask this question to the whole plan. Why should I support this plan? When the status quo, I pay nothing, but with the plan, I have to pay tax. So we have to be prepared. If we try to eliminate or lower the rate, we have to be prepared how to defend that. My second comment is related to the second part of the two reduction. Dental. Again, dental is not something which we have the option of either or. There's a range of dental coverage we can consider. Particularly, I strongly oppose eliminate dental. I would support a scaled down dental benefit. The main rationale is increasingly we have knowledge knowing that a wide range of dental health is inseparable from physical health. And particularly cardiovascular disease is also related to dental health. And so for that reason, if it comes to the time we need to consider cutting down part of the expenditure, for the dental, we should consider the range, not to eliminate that.
Mhm.
And lastly, related to the cost sharing. For the cost sharing, in a mandatory universal healthcare system, cost sharing is actually a tax. So if we come to, again, personally, I oppose cost sharing, but however, if we come to the time that we have to consider cost sharing, we need to structure it so it is equitable. So for example, currently people under 200% poverty line don't have to contribute tax, and therefore they should be exempt from cost sharing. And likewise, for what type of cost sharing should we consider, particularly from the pharmaceuticals? There's one complicating factor we haven't carefully discussed, is most universal health plan has a formulary. Technically, if the drug is in the formulary, whether it's generic or brand name, there should be no cost sharing. So the issue is whether we tax that cost sharing, brand name drugs. The issue is whether the drug is within the formulary. And so this is
Right.
my comment on the cost sharing.
So, Chanwei, do you think that any of these options should be completely off the table or just ordered in terms of
I'm
parity?
suggesting that my first comment was many of those options were framed as either or,
Right, and they could be
there should be
phased.
a range.
Right, I agree.
So
Yeah,
for
but
example,
but
my
for
comment on dental, if it comes to the time we need to consider dental, I oppose eliminate dental per se, but I will support a scaled down dental benefit.
Okay.
And similarly with cost sharing.
Right. So the idea is changing the benefit design is on the table still for you.
Yes, yes.
So I guess my question is eliminating the employer payroll tax credit, should that be like off the table or should just that be like lowest priority?
My personal idea, given that the two rationale, it should be off the table. However, again, that should not be an either or, as Mary Lou mentioned.
Mhm.
And we need more information in public, particularly those who currently receive full benefit of health insurance premium. We need to gauge what are their acceptance level.
Right.
And that might give us a level of whether we need to increase or reduce that, but I oppose completely eliminate that.
Mhm. Okay. Michelle?
Thank you. I think that reviewing or making changes to this draft revenue plan should be on the table. But when I look at our values and principles, to me, the most important one that we haven't had the resources or the timeline to fully implement or align with is community sense of governance. And in addition to not feeling that we have the data to make decisions right now to change the revenue plan, I think the most important data we're missing is the perspectives of Oregonians. And so there's two ways we could look at this. One way is to say the legislature has asked us for a plan. We're going to make decisions without community input, without adequate community input and without full data. And we're going to submit something fairly arbitrary to meet our technical deliverable. Or I would argue our job as leaders is to say a lot of the context has changed since our board was created by the legislature. And our role is to step back and be sensitive to that context and align with our values and principles and say to the legislature, here are the levers. There's trade-offs with each of them. And we strongly recommend that the next step is that we bring together Oregonians to help make this decision. And we have a process in the draft report already by which that could be accomplished. And I think that although an argument could be made for any of these changes, it's going to feel like it's being imposed on Oregonians, and therefore it is not going to be accepted, whether it's objectively or technically the quote unquote right decision, which I don't know that that exists in this context or not. And I think the process matters as much as the outcome. This is what the plan will succeed or fail on. And I don't believe that we can make this decision before September. That's my personal view.
Mhm. Yeah, I appreciate that, Michelle. And I think just like with the implementation strategies, how we're going to lay out a number of options and then comment on what the board thinks is sort of the best approach. I think that's the same thing with these revenue strategies, that we would lay out all of these options. We don't have decision making. We don't have any power. This board is not going to be the final decision maker on any of this. But we have been asked to give the legislature and the governor's office recommendations. They've asked us to think about this and to put forth our best recommendations for how to proceed. And I think we're obligated to do that. And so we're going to recommend a revenue strategy. And we should recommend, well, first of all, we should revise that revenue strategy as much as we feel is necessary before September. And then to the extent that we don't want to revise it any further, we should offer a range of options for continuing to revise it, and then a set of recommendations for what we feel like are the best options according to our principles. We're not going to decide, as you said, and we need a ton of input from the general public. But I think we could suggest, what we think are the best paths to go down and why, because we've spent 2 years now thinking about this, and I think that's what they're looking for. But all of the options would be included, and we wouldn't be making any final decisions.
I appreciate that. I'm just saying, in my view, the best recommendation is here are the levers. We've crunched the data we had available in the time we had available. We strongly recommend that the next step be community engagement before the legislature or the board or any other entity makes further refinements, because that is the next step, is to get that community perspective on these trade-offs, because each one is a trade-off.
Right.
And in a vacuum, decision makers making these decisions without that deep engagement from Oregonians, I do not believe will serve this project. That's kind of my point, is that the recommendation is here are the levers, here there's lots of trade-offs. We recommend that the legislature fund Oregonians coming together and making recommendations on how we approach these trade-offs for a final revenue strategy.
Yeah. I think that's really, really fair. Do you think any of these should not be offered as an option because they are not aligned with our values or principles, or do you think we should offer all of these?
I think we should offer all of these. They're all reasonable, and a reasonable argument could be made for or against many of these elements. There are trade-offs with each of them.
Sure.
And it really comes down to, what do Oregonians support? And, I don't think any of this is necessarily beyond the pale from my perspective.
Yeah, I agree. Yeah. I'm not sure who was next.
I do. We have Chunwei, then Amy, then Mike.
I'd like to echo Michelle's comment that we don't have adequate information and data to make a convincing recommendation or even the options. One particular important issue that Michelle raised, and I mentioned in one of the previous board meeting, was Oregon actually was the world's first example to recognize priority setting. What basically we are doing now is priority setting. And Oregon set the first example to the world that priority setting is not a technical engineering or objective science. It's a subjective political process. And when Oregon started to implement not implement, to publicize the prioritized list and the OHP. Immediately, it suffered a huge criticism. I was in graduate school. We even used that as a case study. And therefore, the leadership, particularly a governor, back then he was a Senate leader, Keith Hubbard, decided to go to the public. They went through at least 2 iterations. Each iteration took 1 full year and went through every counties, almost everyone, and some of the smaller population counties they combined. So they went to almost every county to hold a town hall meeting to gather public input, public opinions, and then they readjusted that priority list. They went through several iterations to the end, because I did a study in the 1990s together with Japanese Ministry of Health funded project to study Oregon prioritized list. By the end, the prioritized list we actually use, you can hardly recognize how much the initial cost utility analysis contributed to that, because it's largely based on public value.
Mhm.
And Oregon set the example. Unfortunately, Clinton administration, when they initiated the first major healthcare reform, they didn't learn from Oregon's experience. That led to the failure, because the Clinton healthcare reform in 1994 was completely top down. They
Mhm.
didn't gauge what Americans want, what prefer. And so we, being in Oregon, we are the pioneer, the world's first state to recognize priority setting is a value, is a political process. And so back to echo Michelle's comment, we haven't done that.
Right.
For example, for those levers, and if we want to use that, I would suggest to do some revision of the wording. Particularly, I mentioned earlier, many of the options should not be either or. There should be a range, possibility of range. And then we take those to Oregonians to see what do they want. And that it has to be both community engagement, but also in a more sophisticated form, such as using something similar with citizens jury or discrete choice experiment, which we ask people in a complex situation. It's not just which you want, but also combination of whether are you willing to pay more tax for this benefit? Are you willing to pay more tax for benefit ABC, etc., etc.?
Mhm.
And currently, we don't have that information. Likewise, in terms of employer payroll tax credit, we also need to gauge on what are the current Oregonians who are employed and receive health benefit, what are their acceptance levels. So there are many issues related to public preference values. We don't have those information. And therefore, this is one of the my big concern to submit that report in September. But in addition, I have other concern. My major concern is a review our interim report is the governance. We propose the public corporations, but we haven't discussed in detail what are the authority of public corporations. For example, do they have the authority to raise tax without going through legislatures? If after implementation, there comes a shortage of revenue,
Mhm. Mhm.
does this public corporation or its board has the authority, or does that have to go through legislatures if
Mhm.
they want to raise tax? Or again, in an unlikely event, does this corporation has authority to suspend or eliminate this universal health plan?
Right. So Chunwei, those are a little bit off topic for today. What I would encourage you to do is comment on the draft report that those concerns should be included in that section.
Actually, this is related to what I'm going to say.
Okay.
In light of those major concerns from revenue target and public preferences acceptance to inadequate discussion detail of the governance, which is very, very crucial, that one of our principles is community ownership, and community ownership dictates the governance structure and principles. So we still have many work to do. Let me just add one more important issue about governance. After implementation, say we have everyone covered in the universal health plan. Every year we are still going to face key decision. Which new drug, which new procedure to cover, which not to cover, and who shall make that decision. So these are also part of the governance.
Right.
So in light of those concerns, I want to make a motion, not for today, but for the next week's the regular board meeting. For the board, I have two parts of the motion related. One is for the board to discuss, to consider whether we should request the legislatures to postpone the delivery of the report to the legislature, to discuss that and potentially for a vote. Because if there's going to be a vote, we need to let the public know. So I'm making this motion for the next week to discuss and potentially to vote, given that there are so many concerns.
So are you making the motion for us to
Consider
decide now?
next week.
Or do you want to?
My motion is for our next week's board meeting, regular board meeting, on two related issues. One, to discuss whether we should and what's the rationale to postpone. And
so
then
you're making a motion to add a topic of discussion to our next meeting.
And potential for a vote. Because if there's going to be a vote, we need to let the public know in advance.
Right. Okay. Is there a second to that motion?
I second.
Okay, then can we do a roll call vote, Isabel?
Yes, we can. I just have too many things open. Okay.
Oh, sorry. I apologize. I forgot about discussion. So there's been a motion and a second to add, I'm a little out of context here. There's been a motion and a second to add a topic of discussion to next week's board meeting about whether or not we should delay submitting our report to the legislature. Currently, we're planning on delivering that by the September 15th deadline, and we would have a discussion about delaying that due date. So is there any discussion on that before we do a roll call?
It looks like Judy Richardson has a
Thank
new
you. I have
hand
a
up.
discussion point. We've had this discussion ad nauseum. I'd recommend the board members go back and reflect on those minutes and even review the recording. I can't remember exactly which meeting it was, but Isabel may be able to let us know. There are huge implications for delay.
Yeah, I'll quickly summarize that. We know that there are so many issues left to resolve on this plan. There's just a lot left to cover. And the point of this report is to generate a legislative concept that would be able to be presented in the 2027 session. And the legislative concept would not be to implement a universal health plan, because as you alluded to, Chun-Wei, there are so many undecided and unresolved issues. That's not what we'd be aiming for in the 2027 session. What we'd be aiming for is a legislative concept, asking the legislator to refer to the voters the idea of building this plan, right? So we'd be saying, can we put on the 2028 ballot a measure that says, do you want the state of Oregon to implement a universal health plan? And very roughly, it would be run by a public corporation, yet to be defined, yet to, have all those details worked out. It would include this kind of eligibility, it would include this kind of benefits, and there would be a personal income tax and a payroll tax. So it would be just as very broad strokes, no numbers on it. Broad strokes, do you want us to pursue this? And if the voters agree to it in 2028 and they say yes to it, that would give authority to the legislature and the state as a whole to really take this on in a way that dedicates the time and the resources and the expertise and the agency personnel that we would need to resolve all those questions. This volunteer board and this teeny tiny staff that we have and this absolutely minuscule budget that we have is in no way able to answer the questions that need to be answered to implement a universal health plan. What we need is buy-in from the legislature that this is an idea worth pursuing, and buy-in from the voters that they are asking the state to take this on. And so what we want in the 2027 legislative session is a referendum to the voters. We want the legislator to say, there's enough to this idea that we want to try it out. And then if the voters agree to it, then we'll go ahead and do all of the investments that need to happen. If we want to have a legislative concept for the 2027 session, it is absolutely imperative that we start working on it now. We have started working on it now because all of those pieces need to be in place before the session starts in January. So delaying our report means we are giving up the option to have a legislative concept in 2027, and therefore delaying the whole idea of a universal health plan for multiple years to come. I don't want to do that. I think we need to act now and do as much as we can now, and getting buy-in from the legislature in 2027. And then hopefully that goes on the ballot in 2028, and getting buy-in on the idea, not the full completed detailed plan, but the idea by the voters in 2028 is our best bet for getting this moving forward and getting the resources we need to work out all these details. So if it's not already clear, I am fervently opposed to discussing this further and delaying the submission of our report. We have had this discussion so many times, and it is really up to, like, getting this report in September is our best chance of getting something for the legislature in 2027. I really don't think it is in this board's interest to delay the submission of our report. Of course, there's tons of work left to do. This board does not sunset. We will continue doing our work, but we have to get something to the legislature in September in order to have a legislative concept ready for 2027. So I really feel like we need to close that option, but I'm interested in the other board members' opinions on that.
Sorry, I left out one important note. By requesting for delay, I'm not talking about delaying indefinitely. I'm talking about delay until early December.
We would lose that early, then there's no time to build anything. The legislature convenes in January. We're out of time then. We don't have the expertise of legislative council and the staffers of the senators and representatives who would sponsor the bill. They need time to prepare a legislative concept, and December doesn't give them enough time. We need time to build the legislation. We're working on it right now. Right now is too late. We're in July, and getting in from July to December, getting something ready, we're really pushing the envelope. If we start in December, it won't make it for 2027. That is far too late.
So I'll go down the list of folks who have their hands raised, and I know Amy and Mike, you guys had your hands up first, so I'll start with Amy if you wanted to comment on. So we're in the discussion portion of this. Or
Yeah,
if you want to save for later.
I mean, it's related to the discussion, but my hand went up to agree with Michelle's proposal about how we word this in the report for the need for, in the next phase, that robust public engagement. And also, I just want to express my deep concern that our current budget, my understanding is we won't be able to bring on or bring back any communications and community engagement consulting until a year from now. And then we will, we're going to have people doing their 30-second clips, and we don't have the bandwidth to appropriately, strategically get in front of that. So I just want to state that. I don't know what the solution is, but it feels like it's in the mix of this other conversation as well.
Yeah. Amy, I appreciate that. I want to respond really quickly. Yes, what you just said, what Michelle said, what Chunwei said about public engagement and needing buy-in from the public is absolutely undisputably true. There's no way this can go forward unless we have more buy-in from the people whose lives this is going to impact. Nobody is arguing that we don't need that. We absolutely need that. What limits our ability to do that, as you alluded to, is money. We don't have the money to do the level of engagement that's needed. And the reason for that is because we don't have the full buy-in yet from I mean, we are funded by the legislature. The legislature determines how much resources in terms of staffing and in terms of budget for consultants and time to do that kind of engagement. The legislature determines that. The goal that we have before us in this September report is to make a strong enough case to the legislature that they give us those resources to say, this is such a good idea. This is such in the best interest of Oregonians and the state as a whole, that we're asking you to double down on this idea and give us the resources we need to do the level of community engagement to get this buy-in. The very first level of community engagement we need is for the general public to vote and to tell the legislature, we want this, make this happen. You know, then we're going to have the community conversation about how to fund it and what levers we want and what the trade-offs we're willing to accept are, right? We need the very first piece of community engagement we need is a vote by the people of Oregon to say, make this happen, whatever it takes to make this a reality. And then we might get a robust investment by the legislature to get the resources we need to then go through this plan and say, what should the role of the public corporation be? What should the, HCPIT be? What should the benefit package be? We need money for that. We need buy-in and investment by both the legislature and then the people of Oregon. And in order to get that, we need to give them a report in September that sells the idea. And if we can sell the idea in September and then get the legislator to say, yes, let's send it to the people, and then it goes on the ballot in 2028, then that's when the momentum will really take off for this. Right now, we're just this tiny little volunteer board with a tiny little budget, and we can't make this happen. So that's the next step forward.
All right, I'm gonna so just we're still in the midst of, there is a motion now, is the discussion part. So Mike, I know you had your hand up from before, but did you want to comment on the discussion about the vote?
I do.
Thank you.
Okay, I appreciate the opinions and passion on this, but I guess I'm of the point of view, however others think, I'm of the point of view that Michelle is correct. I think it's certainly I appreciate that there are pros and cons to this, but I clearly think that Shumway's point of maybe us coming up with some sort of compromise to just report X, but report X without the financial implications, and give us to, let's say, instead of September 15th, December 15th, to actually come up with some additional information. I appreciate that we don't have the resources. I appreciate this is all imperfect, but I guess I think that there may be a false choice here. If we don't do it in September, it's never going to happen stuff. I think something to at least consider to discuss next week is to ask for a deferral of the report, or to have a partial report in September and a partial report in December. I think that if we calmly look at this, I think that there's a more reasonable point. I don't think that it's a false choice if we don't do it in September.
Mike, it's not a false choice. We've been told very clearly by our legislative sponsors that if we can't get them a report in September, that we don't have the time to build a legislative concept for 2027. There's not a false choice there. And by definition, it's not a partial report, but it's an interim report. It's not our last report. We're going to submit a report in September. The board's going to continue to meet. We have an obligation to submit a report every December. So a plan with a revenue strategy is due in September. And then every December, we're still obligated to submit follow-up reports. And so we're going to continue to do our work and continue to work through these issues. And every December, update our recommendations. But it's not a false choice. If we don't submit something in September, we're going to lose the option to have a legislative concept for the session in 2027. And I don't want that to happen, because I think it'll set us back years.
I hear you. I believe that you believe you're right. I'm not sure that what you're saying is absolutely true, and I'd like us to have the next week to think this through so we can do this. I get the energy that people have had, that some of you have had enough. You just want the report to go into September. But that doesn't mean I agree. So I want to go on record with that.
Okay.
Mary Lou is next, and then Michelle.
I guess one of my concerns, Helen, about pushing to get the report in September with more specificity than what it is that you're saying that kind of the legislative concept as you see it will be, that I'm worried about as we try to, we'll have to, it looks like we're going to be putting in something about the personal income tax, about the EPT, those pieces. And we're saying that they aren't for, for real or forever or absolute or whatever. But that's what I think, back to Chunwei's thing, the 10-second soundbite, the people who don't want this will take whatever we put in there. And if it isn't what we really think is going to happen or we want to happen, then it's going to be used and we're going to have real trouble then trying to sell this thing. So that's where my concern is, that that I want to be sure that if we're going to put something in that public report that says this is what this board thinks, that we've had enough. I think we're finally getting to the point where we're having the information, we're discussing it, we're thinking it through, and I'm just nervous about saying that we're going to have that, and that's going to be the section of the report, honestly, that I think anybody's going to pull out and take, and then either sour the well or not, and
Right.
that's why
Yeah, and
I'd like to
I agree with you.
postpone.
And we got to balance that with all of the positives about this, that the healthcare system is in crisis and we're showing up with a solution. And it's a solution that will overall cost less to the state. It'll cost households less. It'll cost businesses less than they're paying now. We've got to make the case that despite the numbers, this is a better plan than the status quo path that we're on. So yes, the onus will be on us to make that case.
Yeah.
You're right.
And I don't disagree, but I'm very worried about what that section is actually going to say and how we're going to say it such that it doesn't get taken and bludgeon us and say, look, this is the only way it can be done. And this is ridiculous.
Right. Well, and that's what the discussion I was hoping to have today about, like, what can we do to enhance our revenue strategy to make it as good as it can possibly be. So that's what I was hoping to talk about today.
Okay. And then I have one other thing, that I have been involved in many legislative concepts, et cetera. And what is put in first often is very different than what comes out in the end. And whether you have a gut and stuff at the end or you change it along the way. So I think there can be going forward with the more general legislative concept with our champions without having the specificity that this report maybe is going to put in. That's all. I don't think it's either or.
So quick reminder, the motion is about holding time on next week's agenda to discuss whether to delay the report. It's not about whether or not we're going to delay the report. There's just a motion to hold time on the agenda to discuss delaying the report.
Yes.
Anybody else with discussion on this motion?
I apologize. Michelle has had her hand up.
Okay.
Pardon for interrupting.
Thank you for this discussion, board members, and thank you, Dr. Chief, for the raising the motion. I will, with respect, I will not be supporting the motion. I think, to me, it's the most important decision. One of the most important decisions that we have to make at this moment is how to frame the report thoughtfully, and that is my understanding, like Chair Blanca just said, of this discussion today, and we just spent 30 minutes discussing something else that I think moves us away from that careful framing, which is disappointing because that's a big loss.
Yeah.
And the difference between September and December, we don't have any additional funding. We don't have any additional capacity. We are not going to have the opportunity in that 3-month timeframe to do additional community engagement that is to the level that we need to impact, substantially what we're submitting. And so I would urge, I've heard pleas from the vice chair, from the chair, from various members of the board, and I would add my voice. The most important thing that we can do is focus and make the most carefully, thoughtfully framed report based on what we know and laying out the path to closing those knowledge gaps, which I think we've discussed already. So that's why I will be a no vote on this motion. Thank you.
And Chen Wei-Chi has his hand up.
I just want to make a quick comment. Even though we have been discussing the issue of whether to delay or not since late last year, however, as we dig deeper to all the information that later become available, we found more information we need, found more information we don't know, and that's why my motion is to have further discussion.
Mhm. Okay, is there any further discussion on the motion? Okay, and again, the motion is to hold time on our next week's agenda to discuss whether or not to delay our reports. Let's do a roll call vote.
Helen Belanca,
No.
Judy Richardson,
No.
Chen Wei-Chi,
Yes.
Amy Fellows,
No.
Michelle Glass,
No.
Mary Lou Henrich, Mary Lou,
Mary Lou, you're on mute.
I'm sorry, yes.
thank you. Mike Leahy,
Mike, you're muted.
Yes.
thank you. And Cheryl Ramirez and Bruce Goldberg are absent. So that's 3 yeses and 5 nos and 2 absents.
That's not correct.
It's 4-3.
Oh, there we go. Yes, that's right.
So we need 5 for a majority. Judy, help me out here. So how does this work then? If we only have 7 of us here, I'm not sure about the rules on this.
I can look them up really quickly. Apologies for not knowing off the top of my head.
Yeah. 5 remains the majority, even if members are absent. So, so let's. I'm not sure how to proceed with that. Mimi's going to look into that. In the meantime, going back to our discussion about the revenue strategy, we only have a few minutes left. Let's switch our conversation to: are there any options of adjusting our revenue strategy, of the levers that we went through, that people think is a great thing to start with, that you think if we need to adjust something, that's the first place we should look? I'd be interested in hearing people's thoughts on that. Judy?
Thank you, Chair. As I mentioned before, the phased in population eligibility for Medicare would be my preference to start with. Not that it's Medicare exclusion, it's a phased implementation for the other reasons that both the transition committee has vetted and discussed. And I think even prior to that, we discussed as a board.
Great, thanks, Judy. Mary Lou?
I think that my first one is around relooking at that employer payroll tax and the tiered effect, whether and actually looking at some numbers there, can that get us additional? But because I'm anyway, I believe kind of tinkering with the payroll tax. The phase in, one of my concerns about the phase in is that some of our administrative savings that we have been hanging on to very tightly and debating how much it is going to be at the provider end, especially the idea of global budgets for hospitals and some of those kind of things that we're saying are going to help save us money. Medicare and hospitalization is a big deal in the Medicare population, higher than the other population. So anyway, I'm just I'm not opposed to the Medicare phase in, whatever that might look like or be, but
Mhm.
I'm just trying to think about the implications for some of the other stuff that we've put in here that can be
And-
then torn down.
And just to be clear, Mary Lou, you're talking about tiering of your first comment, you're tiering of the employer payroll
Yes,
tax itself, not the credit.
correct.
Okay, cool. Anyone else? Chunwei.
Yes, I also support the further exploration on the tiers, both employer payroll tax as well as the tier household healthcare income, personal income tax.
Okay, excellent. Judy?
Sorry, my hand was up from previously.
Oh, sorry. Anyone else have pieces that they really like? So I'm a fan also of the phase-in approach. I'm really interested in the wealth tax. I don't know how much that was explored, but in addition to an HCPIT, adding on an additional tax for like capital gains, and I would really love to see that looked at as a possibility.
I agree.
Any, Mike?
Yeah, I wanted to agree with Helen's point that I think the wealth tax should at least be looked at. I've been looking at that actually over the last week, and think that at least it should be explicitly considered. Thank you.
Cool. Anyone else? What about the idea of excluding dental and vision benefits? And then, like I said, continuing to make those available to folks who are eligible for Medicaid, but then offering those as supplemental insurance for everyone else and just pulling those out of the plan. Mary Lou?
I have strong feelings about the dental. I agreed with, I think it was Chunwei or someone earlier that was talking about, really scaling the benefits, maybe looking at kind of what Milliman put in there in terms of, whether it was the PEB, pretty broad plan of dental, whatever. But anyway, I don't feel as strongly about vision, although I think maybe what I'm thinking is that for children, I'm wondering, that children's vision is really important as they're learning, et cetera. And when I did Care Oregon and vision was a Medicaid benefit, and we looked at how to implement it, and basically people kept telling me that vision is not really a good insurance product. It is, so so I hate kind of putting vision and dental together. I feel much more strongly about the dental, and not just having it be that people who can afford to purchase a supplemental plan on top of the taxes they're paying, et cetera. And it's when you hear out in the public, when we did go to those town hall meetings, I'd say of all the things that when people brought up what they really liked and wanted out of this new plan, dental was really high on the list. I'm not opposed to excluding fertility or that's the one that, and vision, I would not, but dental and some of those other quote complementary unquote medicine, I would like to see those included.
Yeah. Okay. Sorry, who's next?
I know Chunwei has his hand up. Apologies.
As I mentioned earlier, I oppose eliminating dental because a substantial part of dental health is inseparable from physical health. But I'm open to scale down to a range. And as I mentioned, many of those options should not be either or, they can be a range.
Okay.
And then both Amy and Michelle, I apologize. I didn't see which one came first. So I'll just arbitrarily say Amy. Sorry, Michelle.
Yeah, on the dental, and I just, again, like how we frame this in the report, I think is really important, because if you look at the governor's Medicaid task force, excluding adult dental for Medicaid is on the table right now. So
I see, right.
how we phrase this
Yeah.
is really important. Like, because if you make the assumptions,
That Medicaid's still going to cover it.
yeah, it may
Mhm.
not. We don't know how that's going to play out
Yeah, no, it's a
in
really
these
good
next
point.
2 years. So we need to be very, very careful about how we phrase things. I don't know if it's like assuming dental is still covered for under Medicaid, or
Mhm.
whatever, but like we can't make blanket statements
Mhm.
without calling out our assumptions.
Yeah, no, that's a great point. Thanks, Amy. And Michelle?
Yes, thank you. I would just remind the board that we did hear from, I think that it's hard to answer these questions in blanket terms. I think, to Dr. Chi's point, we heard from the deaf and hard of hearing community that for people who use American Sign Language to communicate, vision is an essential health service. So I think, there's the OHP population. There's also people with various disabilities. I think that we need to keep in mind and to honor the feedback that we have heard that impacts people in ways that, it wouldn't impact maybe a person who didn't need to rely on their eyes to communicate.
Mhm.
So I would say, in addition, I am supportive of Vice Chair Judy's recommendation that reducing benefits go to the bottom of the list.
Okay.
To be in alignment with our principles and values. But again, I do think that this is something we need more community input on. And then I would just echo Chair Belanca's point about, I think it's really worth exploring a wealth tax. I think we've seen a real acceleration in wealth shift from the bottom to the top in our economy, and healthcare is a huge part of that. And I think that that would be a really, really aligned place to explore, looking at all of our values and principles.
Great, thanks. I just add one other thing. I personally am in favor of some very limited cost sharing, specifically the examples mentioned, like uh, cost sharing for emergency department visits and for pharmaceuticals. The role of cost sharing in affecting utilization is pretty well established. And while we don't want sort of rampant cost sharing as there is right now, I think some limited cost sharing is really important for overall plan cost containment and driving the best utilization of services. And so I think considering a small amount of ED and pharmaceutical cost sharing, the idea being, all the generics are free, and if you want the brand name, so that there are options for people without copays to get services that they need. But then there are some copays for certain services, perhaps a copay for fertility services or something like that. Some very limited copays that could add to the puzzle. If anyone is strongly opposed to that and thinks that needs to be at the bottom, but I would like that to be one of the ones that we consider off the top. Mary Lou, I see your hand.
My concern about that, Helen, is again where we've talked about the administrative savings and the costs of having the collectability and all of that. So I'm not opposed to, I liked what Chunwei said about a formulary that lists, not only generic, but other cost-effective drugs that don't have a generic, et cetera, and that for those drugs, there would be no cost sharing. But for things beyond that, I wouldn't oppose that on that. But, and the same with emergency room. One of the issues that we have right now around access is that people that don't have a primary care doc or live in a place where there is a lot of lack of accessibility, when it comes down to it, what is your only option? And that is the ER. And so I go back and forth on it. At least it would be the hospitals, you know, trying to collect an amount from somebody, which is a little easier in some ways than all the private provider offices having some kind of copay that they're not able to do, and they have to have administration. So I go back and forth on it, but I do have a concern about especially on the pharmaceuticals. I'm really strongly in favor of that a formulary would be created, and then things so it wouldn't be just that specialty drugs necessarily, or non-generics. Anyway, that's all.
Okay. So what I'm hearing is that if we're going to, as we approach the numbers that we're going to get next week, that if we're going to think about offering some alternatives to those numbers, the things that we should mostly look at are tiering of the employer tax credit and possibly the HCPIT, considering a wealth tax, considering the phased-in approach to Medicare, and that those should be our primary ones that we kind of dig into, and that the benefits piece should be at sort of closer to the bottom of the list, and if we considered it more of a graduated benefit more than an elimination of a benefit, if it's considered at all. But that and the other options on the table are sort of closer to the bottom. Thumbs up if that kind of summarizes where we think we are. Does that sound okay to people?
Yes.
Okay. Okay. So I'm going to check in with Mimi really quick. I was going to just save 2 minutes for public comment. Is there anything else we need to cover, Mimi, other than that?
No, and just for people who don't have access to the chat, according to Robert's Rules of Order, once there's a quorum present, majority vote is sufficient to pass or fail our motion. And coming from our own board policy on consensus process decisions and voting, all official actions of the board, including actions on which there is consensus, must be taken by public vote of all members present. So
okay.
That would mean that there's a sufficient number of people to either pass or fail a motion.
Okay.
Which in this case, the motion failed.
Okay. So in this case, the motion failed. Okay. Thank you for that. I appreciate that. Do we miss anything else, Mimi, or we just do the public comment?
I think we
quick reminder for the board, our meeting is next week, and we're hoping to have a little bit more information and continue this discussion. We may be looking at another virtual meeting July 30th if we need to, depending on how next week's meetings go. We're hoping people will hold that date. That's a Thursday. Again, similar time, 8 to 10, and just holding the time in case we need it. And then the August 20th meeting is when we're going to get a little bit deeper into some information from Echo Northwest on the economic impacts of a UHP. And that is the day when we need to approve the final report, is August 20th meeting. As a quick reminder, Lee has been sending out drafts of the report, and your opportunity to give feedback and comments on the draft is by email directly to Lee. We are not having any time during our board meetings to review the report or to discuss it or to offer feedback on the report. That's not happening at any board meeting. So if you're interested in what the report says and want to provide context or feedback or sort of anything that you feel is missing, your opportunity to do that is now. Please take the opportunity to read through those drafts and send your comments directly to Lee. And anything else?
Sorry. I was just gonna ask, is Bruce going to be with us next week?
Yes, he was unable to make today's meeting, but he will be there next week, and he has some time on the agenda to talk about the Medicaid Advisory Group.
Mary Lou?
I had a quick comment about Helen. It just sounds so definite, like there will not be a discussion. I think the report is probably one of the most important things we're doing, and the fact that we're not going to have time to hear each other to talk about it concerns me.
Okay.
That's all.
Any board member is always welcome to have a one-on-one discussion with me or with Judy or with Mimi in between board meetings, and we can continue to discuss it one-on-one offline if that would be helpful. We need to wrap up the meeting at 10 for external reasons. So I'm just going to say that we had one piece of public comment submitted in writing. Mike Leahy submitted an opinion piece that was written by Kathleen Potempa, encouraging us to include healthy aging outcomes in our quality strategy. I believe there are 2 people signed up for public comment orally. Is that right, Isabel?
Yes, that's right. And one person has let us know that she's not going to share it today, so we'll just have one.
Okay, so we have one person for public comment. I would ask you to contain your comments to 2 minutes, please. I'm not sure who that is, but Isabel, you can introduce them and they can go ahead.
Thank you. Yes, just 1 second. Lou, you should be able to unmute and share your comment now.
Yeah, hi. I have a cat on my back here. So this has been a really healthy discussion. I really appreciate it. I appreciate you're going through. I can only think that the report will establish your accomplishments and what remains to be done. I wanted to also remind that, getting community input is really a great idea. Warren George did a survey not too long ago. I would hope that that survey has been read and gone to. It gives us an indication, while not in detail, as Chunwei would like, it still asks the question, would you be willing to be taxed? And and so they did bring it up. I wanted to raise the question on when you're talking about cost share. As I understand it, Medicaid people cannot be required to do a cost share. So when you put the cost share into place, you need to look at that. It is true, HR 1 is the elephant in the middle of the table. Finally, I would, being tabling as much as I do, when people hear dental and vision would be covered, they light right up. I think for the savings and whatnot for dental and vision, I don't think it's worth it to take it off the table. You will have to limit whatever the limit is and come up with that. So I see my time is out. I could have talked another 15 minutes, but that's all right. Thank you all.
Okay, thanks, Lou. And thank you to everyone for making time for this meeting today. We really appreciate your presence and your comments, and we will see you all next week. Have a good day.